clinician, specialist pathologist. She's a clinical microbiologist, and her interest is in infectious diseases, but specifically HIV prevention and cure. She is the head of the pathogenesis program at CAPRISA, and she will be the first presentation taking us through the excellence in the immune system, which is looking at harnessing Allah's design in the search of HIV cure. Sharana.
Good morning to all. First, a disclaimer. The research that I will be presenting is funded predominantly by the EDCTP and the SAMRC, and any views or associations expressed from an Islamic perspective are solely my own. I will take you through and showcase CAPRISA's current research portfolio, particularly related to HIV cure and prevention. I will describe the flagship study, CAPRISA 012 trial, describe the key findings to date, take you through future research priorities, and end with reflections and lessons learned. So despite extensive prevention and treatment efforts, HIV remains a major public health concern. Young women in sub-Saharan Africa remain disproportionately burdened by the disease. This slide shows results from a community survey conducted in rural KwaZulu-Natal among 9,812 individuals, led by Professor Aisha Kasani in the crowd today. What you can see is that the overall HIV prevalence is 36.3%, with women comprising 44.1% of that. There is therefore an urgent need for novel technologies to be added to the current toolbox. Broadly neutralizing monoclonal antibodies, commonly referred to as BNABs, have emerged as a promising HIV strategy. So what broadly neutralizing antibodies do is that they target different epitopes on the HIV-1 virus, disabling the virus and thereby preventing infection. Several trials to date have been conducted and have shown safety with favorable pharmacokinetics. However, the only phase 2 trial that has been conducted to date remains the impressive AMP, antibody-mediated prevention trials conducted by the networks. Essentially, what this trial showed was that an antibody is able to prevent HIV if the infecting virus is susceptible to the BNAB administered at the correct concentration. The antibody-mediated prevention trial also showed that a combination of antibodies would be required to prevent HIV. In 2013, several broadly neutralizing antibodies were isolated from a woman participating in the CAPRISA 002 acute infection trial. The acute infection trial followed women that were HIV negative until seroconversion and thereafter. One particular BNAB, referred to as CAP256 VRC26.25, was found to be extremely potent, neutralizing 46% of viruses at a median IC50 of 0.01. In simple terms, what that means is that very little antibody was required to neutralize several viruses. In monkey studies, the antibody was able to provide 100% efficacy. So what you see here, on the far left, you would see a placebo control. So on the x-axis, you look at the time in days, and on the y-axis, you can see the viral load. So these are monkeys that have been challenged with the HIV virus, and thereafter the antibody has been administered. You can see with the placebo several lines showing that the viral load is present, and thereafter the 3 graphs that follow show that there are no viral load. In other words, none of the monkeys were infected, even at the lowest dose of 0.08 milligrams per kilogram. The combinations of BNAbs were tested by Wag et al. And what they found was that CAP256 emerged as the best in category antibody and was particularly complementary to VRC07, which is a CD4 binding site antibody, and PGT123, which is a V3 antibody. These preclinical studies led to the development of the CAPRISA-012 clinical trial program. This program is divided into 3 parts. In CAPRISA-012A, it was a phase 1 study that assessed the safety and PK of VRC07, a CD4 binding antibody, and PGT121, a V3 antibody in women without HIV, administered subcutaneously. In CAPRISA-012B, this was a phase 1 first-in-human study that assessed again the safety and PK of CAP256 in combination with VRC07, both subcutaneously and intravenously administered in women with and without HIV. And the results from these trials led to the CAPRISA-012C phase 2 trial, which assessed extended safety and a signal of efficacy in women without HIV. So in CAPRISA-012A, 45 women were enrolled and received both the antibodies subcutaneously. What did we find? We found that both the antibodies were safe and tolerable. Common reactogenicity events, which are signs and symptoms that we look for after a study product is administered, included local injection site tenderness and headaches. Product-related adverse events noted were mild and transient and included proteinuria and elevated liver enzymes. On the right, you can see the administration of VRC07 at different doses subcutaneously. And what you see here is a dose-dependent relationship with the highest dose resulting in the largest number of concentrations of antibodies at 6 months. The CAPRISA-012B trial was a first-in-human trial where 62 HIV-negative women were enrolled and 14 HIV-positive women were enrolled. It was conducted in Durban, in South Africa. Now, just to take you through the complexities of a first-in-human trial, particularly in Africa. In the US, first-in-human trials are conducted in an inpatient setting. Unfortunately, this is not the case for us. This was the first-in-human trial that we conducted as an outpatient. Therefore, we had to design the trial in a particular way. And one of the things we had to look at was increased safety monitoring. We had very late clinics, we had telephonic reactogenicity calls that occurred very frequently, and we conducted enhanced blood safety monitoring. We also had to think about the design of the trial, how the antibodies were administered. Are they going to be administered as a fixed dose or a weight-based dose? Would they be administered intravenously or subcutaneously? So when it comes to intravenous administration, this is debatable, but it's not practical to administer at wide-scale implementation. Subcutaneous administration, on the other hand, is more practical. But one problem that we have is the limitation of the volume of antibodies that can be administered subcutaneously. For the doctors in the room, you know that you cannot go over 3.5 mils subcutaneously. Therefore, we thought of an innovative way to try and get a hold of the situation. There is a product called EDP, which stands for Enhanced Drug Product. It is a recombinant human hyaluronidase that allows for a larger volume of antibody to be administered subcutaneously. The company that makes this product is based in San Diego, and they are called Halozyme Therapeutics. We managed to negotiate an in-kind study product donation. So to take you through the design that occurred after all this discussion, the CAPRISA-012B design was very complex. In the first group, participants received an IV administration of the antibody at escalating doses. In group 2, participants received a subcutaneous administration of the antibodies, also in an escalation. However, we used EDP in some arms and we used EDP in the other arms. We did not use EDP. In group 3, we administered the antibodies in combination, and in group 4, we administered the antibodies as a fixed dose. So what did we find? we found again that both the antibodies were extremely safe and tolerable and were available and detected at 6 months of concentrations high as 20 milligrams per kilogram. So once again, there was a dose-dependent relationship with the highest dose resulting in the highest concentrations at 6 months. Serendipitously, we had added a day 1 safety monitoring blood. And when we added this blood, we realized that there was a transient lymphocytopenia that was occurring in women at day 1. It was not clinically significant and it resolved within 7 to 14 days. It was not a safety concern. However, because of us finding this, the VRC in America had thereafter started adding a day 1 blood, which we just did because of the enhanced safety monitoring. So all their protocols now have a day 1 blood collection because of this finding. The other significant findings that we found were weight-based dosing that was equivalent to fixed dosing. And we know that this is more practical to administer because when you use a weight-based dosing, you waste a lot and it's much more expensive. We also found that the ETP enhanced the subcutaneous administration of the antibody. We found there was increased absorption. We could then administer this sequentially without the need of a nurse, and we could go possibly with self-administered injections as well. So these preclinical findings led to the development of the phase 2 CAPRISA-012C trial, and the purpose of this was to look at extended safety and look for a signal of efficacy. This trial was also divided into 2 parts. In part A, participants received a weight-based dosing of 20 milligrams per kilogram, either subcutaneously or intravenously 4 or 6 monthly. And in part B, participants received a fixed dose. What we did was that we provided a 1.2 gram loading dose followed by 600 milligrams of both the antibodies at 6 monthly concentrations. Now, when you look at a 1.2 gram dose, it is equivalent to 2 vials, and a 600 milligram dose is equivalent to 1 vial. Therefore, there is no wastage. In part A, we enrolled 90 participants, and in part B, we enrolled 1,024 participants. 512 received active product, and 512 received a placebo. The last participant exited the trial on the 30th of June 2025, and unblinding is currently underway. So we will know whether these 2 antibodies are able to prevent HIV or not at the end of this month. Now, whether these results are positive or negative, they still will translate to the scientific field. We will also be able to use these findings for an HIV cure research design. And the reason is because we would be able to answer the question about how many BNAbs, the concentration of BNAbs required both at the serum level and at a mucosal level to prevent HIVs. We would also be able to understand if there's HIV resistance that's occurring and if there's nucleates. We would know whether these antibodies are able to neutralize the viruses that we are seeing, and we will also know whether these antibodies have non-neutralization activity. Now, one of the major challenges to getting an HIV cure is the fact that there's latent virus and there's an establishment of the reservoir. In our study, we found that majority of the long-lived reservoir is established near the time of ART initiation. Based on this, we designed a cure trial called the NEWT-ART Phase 1 clinical trial, where we enrolled HIV-positive, ART-naive adults who are greater than 18 years old, who were due to initiate ART in Durban. They were administered the same antibodies in combination, and there were 3 groups. In group 1, participants received both the antibodies, with ART being administered 1 week later. In group 2, participants received the antibodies and ART on the first day, and in the last group, they received ART only. After 1 year, we did an analytical treatment interruption, meaning that we stopped the ART and we watched the virus. So to let you know, the ATI phase has now been completed, and at the end of this month as well, we will be able to tell you whether the virus was controlled or not. Now this shows you reflections from a 20-year study of CAP256. And as you can see, it took a very long time from the lab to the clinic. It makes us realize that good things really take time and that Allah's wisdom unfolds gradually. When you look at the development of the broadly neutralizing antibodies in this particular woman called CAP256, it is extremely beautiful to see how the immune system creates these broadly neutralizing antibodies. It is definitely excellence in the immune system. And it makes us remember that Allah has placed cures within His creations, and it is for humankind to discover them through knowledge, research, and reflection of His science. When you look at me presenting these results, or anyone for that matter presenting results from a trial, it always looks so effortless. But trust me, there are several challenges that occur during the conduct of a trial. For example, in this trial, the antibodies have a long CDR-H3 arm, and that means that, in simple terms, it was able to turn around and almost clip itself. We had to then create a genetically modified antibody, which was a non-clipping variant, by replacing the amino acid substitution areas. And this set us back quite a lot by many months. There was also several challenges with the manufacturing of the antibody. Another challenge that we faced was when we were able to start the trial, the COVID pandemic had started. And the last challenge was that the EDP that we managed to negotiate, once the results were available to the company, which is a for-profit company, and they saw the phase 1 trial results, they wanted intellectual property of the antibodies, which unfortunately we could not give because that defeats the purpose of creating the antibody to make it cheap for those who need them. So there are lots of challenges and obstacles on the way. And not to say as well that science has very big personalities and there's roadblocks there as well. But it's important for us to reflect and realize that Allah's support is the ultimate determinant of success, no matter who tries to oppose you. And most importantly, if there's anything that any of you take away from this talk, is that HIV still remains a major public health concern. And there still is a lot of taboo and stigma that's related to this. But the Quran doesn't explicitly mention public health or diseases affecting a nation. However, it does show that working collectively for the well-being of society aligns perfectly with public health ethics. Specifically, our Prophet Muhammad ﷺ has said, a well-known hadith, the best of people are those who are most beneficial to mankind. Therefore, as a medical fraternity, as a community, and as a family, it is important for us to be educated, to educate others, to dispel misinformation, so that we can ultimately contribute to the ultimate goal of ending the HIV epidemic, which is beneficial for mankind. I would like to acknowledge my mentors and the leadership of CAPRISA, Professor Salim and Quresha Abdul Karim, Professor Aisha Kasani, who is in the crowd, is a senior scientist at CAPRISA, several of our funders, several of our collaborators. Thank you for your time and attention.
MashaAllah. Thank you very much, Dr. Sharana. There's an old saying about true love being forever. So we always thought that herpes and HIV was forever, but here there's an attempt to try and remove HIV from that equation. Shukran. So thank you for sharing that lovely information and quite novel work in terms of looking at neutralizing antibodies to effect a cure for HIV and the work that's been done in the different phases. Phase 3 is when? Okay, floor is open for questions. Dr. Khan there, I think. Back. Is the mic?
I just wondered, how long does the effect of the antibiotic therapy last? Or, for example, do you need a booster or whatever?
So we see the concentration of the antibodies reaching its peak 3 days after it's administered and lasting for 6 months. However, in this case, you will need to know the point of infection to understand whether the antibody was available in the blood at that point of infection. So what we do is we dose every 6 months, so that at all time whilst there is the concentration of antibodies that's available. The neutralizing activity of the antibodies lasts between 3 to 4 months.
Any other questions? Okay, from our point of trying to understand, what's your endpoint measurement? Are you measuring antibodies, or are you measuring viral load as well as antibodies? And looking for IgGs or whatever.
So in the phase 2 trial, the endpoint is HIV infection. So these are women who started off as HIV negative and then they progress in the trial. They are high risk women, meaning they've been identified to possibly get HIV 60% of the time. And we look at the number of HIV infections that we have, and the statistical analysis is powered to detect depending on the HIV infections. But furthermore, as part of our secondary endpoints, we will look at the resistance of the viruses and whether the antibodies were able to neutralize based on the different viruses that we see. When it comes to the measurement of the antibodies, at the moment we will not know. We've already got our endpoints, so we would be able to look at those who seroconverted versus those who did not seroconvert and look at what the issues were. Was it resistance of the antibodies to the virus? Was it not enough antibody that was available at that time point? We'd also be able to understand if it was a neutralizing problem and if there was a non-neutralizing function also that contributed to that.
Any other questions? No, thank you very much, Sharana, for